What's up, Ninja Nerds? In this video today, we're going to be talking about acute respiratory failure. That includes two types that we'll discuss here. The first one that we'll discuss is type 1, also known as acute hypoxemic respiratory failure. Then after that, we'll talk about type 2, also known as acute hypercapnic respiratory failure. Then we'll go over some of the clinical features that points maybe to the etiologies and pathophys that we're going to discuss. We'll talk about the diagnosis, and then we'll end off on the basic principles of treatment. We won't go down the rabbit hole of each individual treatment. All right, let's get started. When we talk about acute hypoxemic respiratory failure or type 1 respiratory failure, we have to have a basic definition. So hypoxemia is whenever there's low levels of oxygen within the blood, all right? And if it's due to a lung problem, we obviously call that a hypoxemic hypoxia. Now, in these patients, what's the actual level of hypoxia or their O2 saturation that we're concerned with? It actually tells us, hey, there could be some acute hypoxemic respiratory failure. The first thing that you want to look at is their pulse ox, their SpO2. Usually, these numbers are arbitrary, but for the most part, we say less than 90% is somewhat concerning for a patient, especially if they're on like room air, okay? It's even worse if their oxygen saturation is lower, right, less than 90% or even lower, and they're on like some type of oxygen supplementation. That's also a concerning sign. The other thing is if you did an ABG, you take and you stick into the big red, you pull off some blood and you send it off to the lab and they test for the amount of oxygen that's in the arterial blood, the partial pressure of oxygen in the arterial blood. We look for that to be somewhere less than 60 millimeters of mercury. These numbers can vary from source to source, but this seems to be kind of a pretty much standard number across most literature. So look for these two particular things. You walk into the room, you see a pulse ox less than 90%, or you have an ABG that comes back and you see less than 60 millimeters of mercury. That is a concerning sign for acute hypoxemic respiratory failure. The first thing that you should be thinking about as a clinician and for the boards if they present this is what is the likely etiology. And I think the ways that we can break this up is relatively straightforward. So the first thing that I want you to think of, okay, is the problem that the amount of oxygen that they're actually getting is low, very, very low, maybe even lower than room air for some particular reason. Room air is about 21% fraction of inspired oxygen. Let's say that they're at very high altitudes for some reason. Very, very high altitudes. If you're at very, very high altitudes, this could potentially precipitate a situation where there's very low levels of inspired oxygen. So at high altitudes, well, sometimes we actually can potentially see this, high altitude levels can really cause less FiO2 to be delivered to the alveoli. Now, how does that actually work? Obviously, you take a breath in, the oxygen inside of the atmosphere is going to be sucked down into the bronchial system, go to the alveoli, and if there's less amount of oxygen, that means less will be diffused into the actual capillary blood. That means that the PaO2 or the SpO2 will drop as a result of less inspired oxygen, the fraction of inspired oxygen that we're actually taking in. That's one type of thought process. The second thing, if it's not due to a decreased FiO2, all right, then it could be due to hypoventilation. The patient's not taking in adequate amounts of tidal volumes. They're not taking in enough air. If they're not taking in enough air, they're not taking in as much oxygen. They're not putting as much oxygen into the blood, and that will drop their oxygen levels within the blood. What could be the reasons for patients having hypoventilation? And when we talk about ventilation, there's an important concept here. When we talk about ventilation, there's actually a formula that I really do want you guys to remember here. We're going to write it right here. But for ventilation, what we call minute ventilation, it's actually equal to the tidal volume multiplied by the respiratory rate. So minute ventilation, right, is basically determines the amount of air that we're actually ventilating is dependent upon these two factors, tidal volume and respiratory rate. If a patient is not taking in adequate tidal volumes, that'll lower their ventilation. If they're actually breathing at a very slow rate, that'll lower their ventilation. So we have to think about things that would actually cause the patient to not be able to breathe, so they won't breathe. And if they're not breathing, they're breathing at a very slow rate, or they can't breathe. They're not taking in adequate amounts of tidal volumes. In those situations, you want to be able to assess those problems. So let's break it up into two potential theories of why the patient has hypoventilation. One of those theories is that they won't breathe. And so you have to think about what actually controls breathing. If you guys remember, our central nervous system, we have these respiratory centers that are basically responsible for our breathing, particularly within the brainstem, the pons medulla area. If a patient, for whatever reason, has some type of damage or disease process that injured these neurons, will you be able to send action potentials down these particular neurons, down the phrenic nerve, down the intercostal nerve to contract those muscles and bring air in? No. So you'll decrease the patient's electrical activity to their intercostal muscles and into their diaphragm. And so because of that, any kind of CNS disease process. So think about patients who maybe have some type of stroke. So they've infarcted this piece of tissue. They have a tumor here that's actually compressing onto this area. These would be particular things to be thinking about. A second reason is that you have something that is really shutting down or sedating or inhibiting and preventing that actual respiratory center from being able to trigger the respiratory drive. What could be things that actually would suppress a respiratory drive? Some degree of sedation or analgesia. So maybe it could be opioids and having too much of them, overdosing on this, or benzodiazepines. In these situations here, this could be potential reasons because you're having a lot of inhibition or dropping of their respiratory drive. So these drugs that you may be giving the patient may be inhibiting, suppressing the respiratory drive, not sending action potentials down these intercostal and phrenic nerves, and then therefore they're not going to be taking in adequate tidal volumes. If they don't take in adequate tidal volumes, they're not going to bring enough air into the alveoli, they're not going to allow for good gas exchange. Done. What's another reason that the patient could have less ventilation, hypoventilation? We already know that if we actually suppress the respiratory center, we have less drive to breathe. So there may be a drop in the respiratory rate, right? They might not be taking in deep breaths. They might actually become apneic. So that's an important concept. What if the patient can't breathe? So their respiratory drive is intact, but something's wrong with the structures around the actual lungs. Maybe it's the lungs, the airway itself, maybe it's the pleura, maybe it's the chest wall. If there's some type of abnormality here, but the respiratory drive center is intact, the actual central nervous system is telling the actual structures that are involved in breathing to breathe, then we got to think about what's causing them to not be able to. So go to the chest wall. What kind of things could alter us from being able to properly take in adequate tidal volumes? What if I didn't have a lot of flexibility within my actual thoracic spine? What if I had like some type of abnormal curvature and I had scoliosis or kyphosis, or I was super obese? That's really going to make it hard because when patients are really obese, you actually push their diaphragm up really, really high. On top of that, you have to be able to breathe against this large type of tissue on the chest wall. So in those situations, it's really hard to bring in adequate tidal volumes. So think about three particular types of things. One is if they have some type of chest wall deformity, such as maybe kypho, scoliosis, or massive obesity. Then what if there's a big whopping effusion that's actually sitting within this pleural cavity, and now you have to be able to inhale and try to expand the lungs into this big fluid cavity that's pressing on it. That's not going to allow for you to be able to completely inflate those lungs. And so situations where you have big pleural disorders, such as, I think pleural effusions would be more of an important one to be able to remember here. Okay? Now, the next thing is, what if the actual chest wall is intact? There's no kyphoscoliosis, there's no obesity. What if there's no pleural disorders, but it's the nerves? You know how you have to have nerves that actually are going to stimulate these particular muscles. Now, if there's some type of damage to the nerves, they're inhibited for some particular reason. Can they stimulate these muscles to be able to contract? No. If they don't contract, are you going to be able to allow for the expansion of the chest wall, bring air in? No. Will you be able to ventilate properly? No. So think about disorders of the nerves. Something particularly maybe something like Guillain-Barré syndrome, where they demyelinate the actual PNS neurons, or some type of cervical spinal cord damage. So sometimes that's a really big one to be able to remember. So some type of cervical spine damage, especially where it involves the phrenic nerve. Okay, so if you have any kind of compression of the cervical spinal cord or damage of that, that could be an important one. Sometimes you may see this in like ALS or polio or botulinum toxins. Those are kind of rarer cause, but I would think about these two. Muscles. What if there's actually disease of the muscles, where the muscles aren't able to contract properly, or they're not getting enough signal to be able to allow for them to contract and actually increase the thoracic cage volume and bring air in? In those situations, think about maybe myasthenia gravis. Myasthenia gravis, you know what else? These are really rare, but dermatomyositis, polymyositis, maybe even if you really want to, muscular dystrophy may be another one to think about. These are muscular disorders where the actual muscles themselves are weak or damaged and not able to be able to contract properly and generate enough force to increase the chest cavity volume and bring air in. That should make sense. So they have a good respiratory drive, but they can't breathe properly because they got some type of chest wall deformity, or they're obese, or because they have some type of pleural disorder. If that's not the case, think about the nerves and the muscles, maybe some type of neurological disorder or muscular disorder. If you've gone through those, the next thing to think about is, could it be something with the airway, something with the actual like lung tissue itself, or something with the actual bronchial alveolar system? So if that is the case, here's what I want you to think about. Big thing here. If I have a big upper airway obstruction, so let's say for whatever reason, there's some type of obstruction of this upper airway. Maybe this is a tumor, maybe this is a foreign body, right? Maybe this is a big fat mucus plug, or sometimes in patients who get like a lot of edema of their larynx, they can have like laryngospasm. Sometimes that massive obstruction within the airway can prevent air from being able to get down into the alveoli. And so because of that, that means that less of this air is going to be able to get to this alveoli, less oxygen moves into the blood. So think about big upper airway obstruction. What could be big upper airway obstruction? I already kind of told you. It could be a foreign body, could be a tumor, or it could be laryngospasm. So I want you to think about these as more of the upper airway obstructions. But what if we get into the lower airway obstructions? What if for some particular reason we have a patient who has something called COPD or asthma? So think about COPD. Another one I want you to think about, because this is a very weird, interesting type of disorder. Sometimes this may slightly confuse people. So here's what I want you to remember. In these disorders, oftentimes we say, oh, their problem isn't being able to get air in, Zach. I thought from the COPD and obstructive lectures it was getting air out. That is true, and that's the problem. They can't get air out. Because they can't get air out, what happens to these poor patients' lungs? They can't get air out. They're going to be hyperinflated. So they have this massive hyperinflation. Now I dare you to take a deep breath in, as deep as you possibly can, and then hold it. Hold it at the peak of when you take that deep breath. Your lungs are filled to the max. Try to take a deep breath on top of that. Imagine how difficult it must be to take a breath on top of a hyperinflated lung. That's what these patients struggle with. So whenever they have hyperinflation, their lungs are already completely filled. So you have this massive increase in total lung capacity, and you have to try to breathe beyond that. On top of that, their diaphragm, flat, right? If it is flat, imagine, whenever you actually take a breath in, what happens to your diaphragm? It's supposed to kind of like try to come down. It generally becomes flat, or it domes downwards to be able to increase the thoracic cavity volume so you can expand the lungs. If it's already flat, and you're supposed to be able to take a deep breath in and contract that muscle to try to bring it down even more, imagine how difficult that's going to be. That's going to require a lot of effort. So in these patients, think about, yes, the problem with COPD and asthma is more getting air out, but that is the issue. They can't get air out, they hyperinflate their lungs, and they can't take in deep breaths. So they hypoventilate, they take in lower volumes because their lungs are already filled and their diaphragm's already flat. All right? That'll cover these parts. So we have a patient, comes in, low SpO2, we get an ABG, they have less than 60, we think hypoxemia. Is it low FiO2, where they're at high altitudes? Pretty rare cause. Is it hypoventilation? Is there a CNS catastrophe of some reason, big sedation, drugs like opioids, benzodiazepines, or some type of stroke or tumor, okay? That's not it. What if they can't breathe? Chest wall, pleura, nerves, muscles, then get into lungs and airways. Big upper airway obstruction or hyperinflation like COPD, asthma. If that is not the case, then you go to the next thought process, which is going to be VQ mismatch, decreased diffusion capacity, or some type of shunt. Let's talk about those now. All right, so the next concept that I want you guys to think about, and this is oftentimes tends to be the most common cause, is a VQ mismatch. So there's something wrong between the ventilation of the alveoli, so basically how much oxygen gets into the alveoli, and then how much perfusion is moving through the pulmonary capillaries. There is a mismatch between the two. In a perfect world, you want normal ventilation, normal perfusion, but sometimes that's not the case with pathology. There may be a decrease in ventilation or a decrease in the perfusion, so you have to be able to think about those things. So what kind of things would cause a decreased ventilation, not enough oxygen to be able to get into the alveoli? I want you to think about this at 3 levels. One is there's a problem with the airways delivering oxygen to the alveoli. One, there's a problem with the alveoli, or one, there's a problem with the pulmonary vessels, and it makes it a lot easier to think about. If it's an airway problem, there's got to be some type of bronchospasm or mucus plug that's narrowing the airway. It's making it so much smaller that it's really hard. It's easy to get oxygen to this alveoli. So oxygen is really going well into this one, but it's not moving very well into this one. So because of that, you're getting less oxygen into this alveoli and an increased amount of oxygen into this alveoli. So there's a good ventilation to this one and a poor ventilation to this one. In this situation here where there's some type of mucus plug, so maybe there's a little bit of mucus within the airway, or there's bronchospasm, so maybe you can see this in situations like a little bit of mucus within the airway, or such situations like COPD or asthma, you may be able to see these. but there's less oxygen getting into these alveoli. So at this point here, if the perfusion is normal, so your Q, the perfusion is normal, then what's going to happen here? You're going to send deoxygenated blood into this actual pulmonary capillary blood, and then oxygenated blood into this pulmonary capillary blood. So there's a VQ mismatch at this particular alveolar capillary interface. And this could be one particular reason. So think about small mucus within the actual bronchial system or bronchospasm of the bronchial system, which is narrowing the airways and reducing the amount of oxygen getting into the alveoli. Things like maybe COPD, asthma, etc. Okay? The next type of thing that I want you to think about is what if it's at the alveolar level? So it's not an airway problem, it's an alveolar process. So there's something that's filling the alveoli, or the alveoli has collapsed. So if the alveoli is collapsed, this is called atelectasis. So there's collapse of the alveoli. If it's collapsed, it's smaller. If it's smaller, you're not going to be able to get as much oxygen into that poor little alveoli. So therefore, there's going to be a mismatch now, because here you can have normal perfusion, but there's a decrease in the ventilation process, so there will be less O2 going into this pulmonary capillary blood. That's going to lead to hypoxemia. In the same situation, there could be some type of material that's actually plugging up or blocking oxygen from being able to get into this alveoli, because there's some type of material, let's say. And depending upon what that material is in the alveoli, could determine the underlying etiology. But this is blocking the O2 from being able to, it has to move against fluid or pus or blood or lots of protein and cellular debris across this and get into the pulmonary capillary blood. That's definitely going to cause hypoxemia, right? So what are these things? What if it's pus? Then you think about pneumonia. Sometimes this can even be ARDS. What if it's some type of fluid? Well, then you can think about maybe cardiogenic pulmonary edema secondary to CHF. Sometimes it could even be due to ARDS. What if it's due to blood? Then it could be situations like diffuse alveolar hemorrhage. And there's a lot of other miscellaneous types of situations, but they're not super high yield, where you can get lots of lipids like lipoid pneumonia, you can get calcium like pulmonary calcinosis, a lot of these different types of things, cancers and yada, yada, yada. But I don't want you to focus on that. I want you to focus on the most common ones. So in this situation where you get a VQ mismatch is because of the alveoli collapsing or the alveoli is filled with some type of material, whether it be pus, blood, or some type of fluid. Okay, think about those particular things. The last one is that there is nothing wrong with the alveoli. These alveoli are perfectly ventilated. There's no mucus, there's no alveolar atelectasis, there's no alveolar filling process. So oxygen is going well into these alveoli. They're ventilating perfectly. But there is a clot in one of these pulmonary vessels. And so the blood flow to be able to pick up the oxygen is the problem. And so you never get this gas exchange process because not enough blood or no blood is coming to this actual alveolar capillary interface. And so even though you have good ventilation, the perfusion is what is decreased. And so again, if I have a clot right here, I'm not going to be able to allow for this ventilation process. And so blood is just going to completely bypass this area, not get oxygenated. And because of that, the blood that will leave this will still have low levels of oxygen because it's never going to be able to pick up the oxygen from the alveoli because there's a clot blocking the gas exchange process. In this situation where you have a thrombus of the pulmonary vessels, think about a PE, okay? All right, so VQ mismatch, here's the way I want you to think about it. There's some type of small mucus or bronchospasm. That's probably gonna be the least likely one. Or there's atelectasis of the alveoli. There's an alveolar filling process with pneumonia, ARDS, pulmonary edema, or diffuse alveolar hemorrhage. That's going to be probably one of the most common ones. And then the last one is that there's some type of PE that's blocking the perfusion to the alveoli to pick up the oxygen. That's another really common one. Don't forget these. This one can be kind of a last one that you could think about in situations such as maybe COPD or asthma, and then some of the actual bronchopneumonia. So sometimes you can see this in bronchopneumonia. Okay. The next one. This one's very, very relatively rare. I wouldn't even really kind of think about this one, but for the consistency of being all-engulfing approach here, we should think about decreased diffusion capacity as well. So generally, this has nothing to do with the alveoli. This has nothing to do with the perfusion. This has nothing to do with the actual bronchial system or the airway system. It's the interstitial space that is the problem. And there's a thickness of the respiratory membrane, or there's a decreased surface area of the respiratory membrane, and that tends to be the problem. If there's this big thickness because there's a lot of fibrosis, so what if a patient has a massive interstitial lung disease? If you have a big old interstitial lung disease, that thickens the actual respiratory membrane. It's harder for oxygen to be able to move over into this actual capillary system. Or what if there's a big waterlogged, fluid-logged, interstitial type of edema that's actually locking up all this area and blocking the diffusion of oxygen into here in situations like severe pulmonary edema that's affecting the interstitial fluid? That could be another reason. Or you have a decreased surface area and emphysema. All of those things are decreasing the diffusion across the respiratory membrane. All right, that's enough said about that one. The last one that I really want you guys to think about as well is a shunt. So this one tends to be the worst. So a shunt is basically when, you can think about it in two ways. One is that blood actually never goes to the lungs and never is involved in gas exchange whatsoever. So there's no gas exchange process that's occurring because we're bypassing the lungs, or bypassing a huge portion of the lungs. So that's the way I want you to think about it. Either we're completely bypassing the lungs, or we're bypassing a huge portion of the alveoli and just having blood pass right by it. Let me explain why. In a situation where you're not even going through the lungs, it's because you have an intracardiac shunt. So if you have an intracardiac shunt, what you're looking to see here is that blood is going from the right side of the heart, deoxygenated, into the oxygenated system. You're pushing low oxygenated blood into the oxygenated system. And so now you're going to mix the blood. That's going to definitely drop the actual oxygen concentration within the blood and cause hypoxemia. So think about maybe ASDs, VSDs, PDAs, all of these things that are acting, particularly they'd have to have Eisenmenger syndrome, if you remember from our congenital heart disease. They have to have some degree of right to left shunt. So usually in their early life, they usually are left to right, but if they have Eisenmenger syndrome, they may develop a right to left shunt. So think about those particular types of situations. The other one is a really interesting one where maybe the pulmonary vessels, so you have your pulmonary arteries and they're supposed to go to these alveoli and they form these different capillaries. But sometimes due to a congenital malformation, the capillary network doesn't even involve gas exchange because there's such a big like nidus where there's this abnormal capillary kind of connection between the arteries and the veins. And so no gas exchange occurs at multiple areas of the lungs. And so because of that, you kind of just think about this connection where you go from an artery to a vein without even having any gas exchange. This is called a pulmonary AVM. Relatively rare, but something to think about when we talk about how to diagnose these later. All right, so think about shunt, intracardiac shunt, ASD, VSD, PDA, some right to left shunt, or a pulmonary AVM. Here's the other thing. Remember I told you that VQ mismatch was one of the really big problems. Well, here's what I want you to remember, that VQ mismatch, if it becomes really severe, can actually develop into a shunt. Let me explain what I mean. Remember, a shunt is where there is a massive, there's either no blood moving through the lungs, so there's no gas exchange that's occurring at the lungs, or there is very little gas exchange that is occurring at the lungs, almost none. Here's the way I want you to think about this. Let's say for whatever reason, a patient has a huge mucus plug. For some reason, they have a huge mucus plug of this entire right bronchus. No air is going to go into multiple alveoli in this entire lung. This entire lung will collapse, right? They'll develop massive, severe atelectasis. And severe atelectasis, now all of these alveoli in the entire right lung will have no oxygen going to it. If no oxygen is going to these alveoli, what do you expect to happen in this situation here? Are you going to be able to deliver any oxygenated blood into these alveoli? No. And so because of that, you're not going to be able to deliver any oxygen from all of these alveoli into the actual pulmonary capillary blood. There's going to be almost no O2 that'll get into this actual pulmonary capillary blood because they're going to be completely blocked, no air getting into these alveoli. And that is the problem. Oftentimes what happens in these situations when these alveoli aren't getting a good enough ventilation, you know what happens to the pulmonary capillaries? It's a really interesting concept. Imagine here, I have an alveoli, okay? And then here I have another alveoli. And imagine here is the actual pulmonary blood. If in this situation here, this alveoli is well ventilated, then I'd have good blood flow to that actual alveoli. But in situations where maybe this alveoli is very, very poorly ventilated, it's filled up with pus or there's no air in it, I will not want blood flow to go to this area. And so what often happens is that these pulmonary vessels undergo intense vasoconstriction. And because they undergo this intense vasoconstrictive response, they completely bypass. No blood will go to this alveoli. And you'll try to shunt it to other areas where maybe other alveoli tend to be well ventilated. But guess what? This entire lung is not well ventilated. So you're going to have a massive shunt here, where even if you try to shunt blood into other areas which may be slightly more ventilated, it's still not going to be good. So think about that. If a patient has a massive hypoxemia, not responsive to oxygen, think about a big, big mucus plug that's causing massive shunting because multiple pulmonary vessels are vasoconstricting, trying to send blood elsewhere, okay? This is the very persistent concept to remember with shunting. And very severe, poorly ventilated alveoli is that whenever they're poorly ventilated, you'll have what's called pulmonary vasoconstriction to take blood away from this pulmonary vessel going to this alveoli, and instead, that blood that you could be wasting going to that one, send it to this well perfused and well ventilated alveoli. So increase the actual blood flow to the well ventilated alveoli, decrease the blood flow to the poorly ventilated alveoli. That's kind of the concept of shunting. All right, that's one thing. Now, go back to all the other concepts. If it's not severe atelectasis, then it has to be something that's filling up the actual alveoli. So now the alveoli is filled with a massive amount of fluid. What is this called? Severe pulmonary edema. So if a patient has severe pulmonary edema, that's going to fill up multiple alveoli. Multiple alveoli won't participate in the ventilation process, and they're not going to be able to give oxygen to the actual blood. So multiple pulmonary capillaries will vasoconstrict and take blood away from those alveoli and try to send it to another well-ventilated alveoli, okay? But massive pulmonary edema will be one. Or you're filling them with a massive amount of pus. So there's a massive amount of pus that's actually filling within these actual alveoli. So this could be serious pneumonia. So a very socked in pneumonia, very severe socked in pneumonia. And the last one that I want you guys to think about is if it's not due to a lot of pulmonary edema, it's not due to atelectasis, it's not due to a lot of a really socked up type of pneumonia, what are the other kind of things that it could actually be considered to be? ARDS. And so ARDS is kind of when you have a mixture of fluid and proteins and a lot of like white cells and even a lot of infection that can actually sock up in this entire lung area. So this could be thinking about ARDS as well. So you can have VQ mismatches that cause shunt when they just get more severe. So atelectasis, pulmonary edema, pneumonia, ARDS, these would have to be very severe to cause a shunt, but that is another possibility. So remember, shunts are basically whenever there's almost no blood going to the actual lung, no gas exchange processes occurring within the lung because you're bypassing it. Whether it's an intracardiac shunt or a pulmonary AVM, or very little gas exchanges occurring at the lungs, very, very little due to severe VQ mismatch, such as severe pneumonia, severe atelectasis, severe pulmonary edema, or severe ARDS. Okay, that covers the pathophys. I think that this now takes us from acute hypoxemic respiratory failure into acute hypercapnic, which guess what? It should be super easy now because we've already covered a part of it. I'll see you there. All right, my friends, now type 2 respiratory failure, also known as acute hypercapnic respiratory failure. Guess what? One of the pieces that was a cause of hypoxemia is the primary cause for hypercapnia and acute hypercapnic respiratory failure. So let's test your knowledge and then understand why this happens. The primary cause for acute hypercapnic respiratory failure is hypoventilation. Do you guys remember that? Remember what I told you was the formula for ventilation, particularly miniventilation? Miniventilation was really equal to your tidal volume multiplied by your respiratory rate. So if a patient has a drop in their respiratory rate or a drop in their tidal volume, that will cause a drop in their minute ventilation. And then if their minute ventilation is decreasing, their PaCO2 will increase. Let's explain why. Basic concept. Remember when we were talking about oxygen moving from the alveoli into the blood over in the acute hypoxemia? So if there's decreased ventilation, there's decreased movement of oxygen to the alveoli, decreased movement of oxygen into the blood. In the same way, decreased ventilation leads to decreased CO2 moving from the pulmonary capillary blood into the alveoli and from the alveoli out into the atmosphere. So if there is less ventilation, that means air coming in and out. Don't forget that. That means less CO2 is leaving and exhaled out. that means CO2 will start to build. What happens, if you guys remember from that equation, that CO2 plus water yields something called carbonic acid, and then that disassociates into protons and into bicarb. As we increase the CO2, what does that do? Le Chatelier's principle, shift it to the right. We make more protons. What does protons do to your pH? They drop the pH. So in these patients, I'm going to see an increased amount of CO2 within their blood and a decreased pH of their blood. So oftentimes we can't pick this up off a monitor. Sometimes if the patient is intubated or ventilated, or we can stick a monitor down, we can check what's called in-tidal CO2. But the proper way is to send off a VBG or an ABG and get the amount of actual CO2 that's in their blood, preferably ABGs. And if we get a PaCO2, the partial pressure of arterial CO2, it has to be at least greater than, and again, this is a kind of like standardized number, greater than 50 millimeters of mercury. Now on top of that, we also look to see, because usually in these situations where there's acute hypercapnic respiratory failure, it's acute. So sometimes if you build up CO2, you should see a drop in pH. Over time, if it's chronic and the patient has time to compensate, what would happen? They would actually start trying to reabsorb bicarb, excrete protons, and they would compensate metabolically. But acutely, they might not have enough time. So we would expect the pH to drop less than 7.35. So we would expect to see some type of respiratory acidosis in this patient. That's a very common particular finding. Now, what would cause CO2 to build up? Go through everything that we talked about just to recap. Hypoventilation due to CNS not triggering your actual respiratory center, triggering the actual process of breathing, so you won't breathe. CNS disease, CNS depression due to opioids, benzodiazepines, any kind of thing that can actually suppress the respiratory drive. Or you can't breathe. You got the drive, but there's something wrong with your chest wall or your pleura, kyphoscoliosis, obesity, or pleural effusions. There's something wrong with the nerves, like maybe particularly Guillain-Barré syndrome, cervical spinal cord damage, ALS, polio, botulinum toxin, or muscles. So this could be myasthenia gravis at the neuromuscular junction, dermatomyositis, polymyositis, muscular dystrophy, etc. And if it's not that, it's some type of upper airway obstruction that's blocking the CO2 from being able to get pushed out, such as a big upper airway obstruction like a tumor, a foreign body, or some type of laryngospasm. And if it's not that, it's due to hyperinflation disorders where they can't take a deep breath in, but they're also, guess what? Air trapping. They're not getting air out because their bronchioles are collapsing or they have such bronchospasm. And in those situations like COPD and asthma, they trap air and they trap CO2. These would be the things that I need you to think about for acute hypercapnic respiratory failure. Now, when we talk about the features, they're generalized, okay? Not everybody is going to have the same exact features. Classically, if a patient has hypoxemia, their reflexive reaction is to breathe faster, so they become tachypnic, tachycardic. They may have some degree of changes within their mental status as well. As people build up CO2, they may usually, because they're having a decreased tidal volume and a decreased respiratory rate, they may have very shallow breaths. They may actually become apneic. They may have some degree of CNS depression or somnolence or altered mental status. So again, very generalized. But ways that can help you to key you up to the actual etiology or the pathophysiology, just a few of these, is if a patient has a fever, cough, maybe they actually have a pneumonia that's triggering this process. And the pneumonia is a socked up area of alveolar filling, and that's causing a VQ mismatch. Or it's an upper airway obstruction that's causing hypoventilation. So look for stridor in the upper airways. Look for wheezing during expiration in the lower airways potentially. The other thing is crackle. So if their lungs are filled up with lots of fluids, and whenever they take a deep breath in, it sounds like Velcro is being ripped apart. That could be fluid within the actual bronchial airways, and that's something like ARDS or lots of pulmonary edema. If they have associated muscle weakness of other extremities besides their diaphragm and intercostals, their eye muscles, their upper extremity muscles, thinks about those actual muscular disorders, such as myasthenia gravis, such as Guillain-Barré syndrome, such as muscular dystrophy, dermatomyositis, polymyositis, etc. And if there's some degree of altered mental status, neurodeficits, they're very difficult to arouse, a decreasing level of consciousness, they have sonorous respirations, they're not opening their eyes or following commands, there's a decreased level of mental status, a declining GCS status. Think about some degree of CNS depression. Is there a neurological catastrophe like a stroke, a tumor, a bleed? Or are they not actually taking drugs? Is there an opioid overdose? Is this a benzodiazepine overdose? Is this some type of drug overdose? Think about those particular things. That might lead you down to what's the actual cause and how to treat them. So now that we've done that, we come to the next challenging part, how to diagnose these two. All right, so now we move on to the diagnostic approach of these respiratory failures. So you get type 1, type 2, acute hypoxemic or acute hypercapnic. Now, when we think about these, I hate saying it, but it is actually a relatively important thing to consider, especially for your clinical vignettes, is that you want to get an ABG on these patients. And the reason why is on the clinical vignettes, they're actually going to have you kind of determine which phenotype of hypoxemia is this. Is this a low delivered FiO2, such as high altitude? Is this a hypoventilatory cause? Because in those situations, they have a normal AA gradient. And I'll explain what the heck that means in a second. Or is it the other phenotypes, which is this an increased AA gradient due to a VQ mismatch, a shunt, or very, very uncommon, a low diffusion capacity? In those situations, we have to kind of then talk about what the heck is the AA gradient, because it's something you may see on your exam. Now, I doubt that they're going to require you to do any calculations, but to at least have an understanding of what the heck AA gradient means, I'm going to give you a kind of a quick, brief overview of it. The AA gradient is really kind of looking particularly at the alveolar partial pressure of oxygen and subtracting it from the arterial partial pressure of oxygen. And that tells us the difference between the two, right? It really tells us, for example, if I bring O2 into this alveoli, ventilate this alveoli, right? And I have a very particular pressure there in that alveoli, the PaO2. And then from here, I look at how much of this actual oxygen moved into the actual pulmonary arterial blood and then therefore went into the systemic circulation. What I'm going to measure here is how much of that oxygen actually got into the systemic circulation. So if, for example, most of the O2 that I'm moving from this actual alveoli into the blood is about the same, if for example, there's a good exchange process that's occurring. There's a good exchange process that's occurring that is between the alveoli and the actual capillary blood, meaning there's no impaired gas exchange. What kind of diseases have impaired gas exchange? VQ mismatch, shunting, and some type of diffusion capacity problem. Which ones do not have impaired gas exchange? Is a problem with the patient either not bringing enough O2 in or not bringing enough volume of air into their actual lungs. Those would be situations with a normal AA gradient, right? So that's the basic concept. Now, how do we actually determine this? If you were to do this, and we'll do a case example on one of these when we talk about our cases, but the partial pressure of oxygen in the alveoli is calculated off of this equation. So it's FiO2, which if we're taking room air, that's 21%. The inspired pressure, which is usually the atmospheric, so 760 millimeters of mercury. The pressure of water, which is usually 47 millimeters of mercury. And then what we do is we subtract that from the arterial partial pressure of CO2 over the respiratory quotient, which is 0.8. Now, it's like, oh, Zach, I can't remember all these. Don't worry. Oftentimes, if the patient is breathing room air, we simplify this whole left side of the equation by making it 150. That's just what you'll get. 21%, 760, 47, you do all that, you get 150. Then all what we need is to really look at the ABG, and from the ABG, I can get my partial pressure of arterial CO2 and put that over this constant of 0.8 for the respiratory quotient. And then I can get my PaO2. Then all I need to do is get their partial pressure of arterial oxygen from the ABG and subtract it. And what that gives me is that patient's AA gradient. But then you know what you actually have to do is you have to compare that AA gradient at that moment of time of what would be an estimated normal AA gradient for that patient. So for example, if the patient had a normal AA gradient, we would expect that the AA for this one, let's just say for one example, it was normal. So we have normal and then we have increased. Let's say that this was 120 for that AA gradient, and when you calculate it for this patient, it happens to be 120. Well, then these are pretty close to equal. So that's a normal AA gradient. But let's say for whatever reason that the patient's AA gradient when you do this was 120, and what you calculated, actually let's make it even like higher, let's make it extremely higher. Let's make it like 340. And what you actually calculate for this patient is 120. Then you're looking at a huge difference. The AA gradient for that you actually calculated off of this is massively higher than what it should be. That's an increased AA gradient. And really what we're looking at to really kind of differentiate these without getting too complicated with the equation is if you have a normal AA gradient, you can kind of just look at the patient's PaCO2. If the patient's PaCO2 is really high, what does that mean? That means that they have a hypercapnic respiratory failure or acute hypoxemic due to hypoventilation. They're not ventilating. And if they're not ventilating due to a decreased tidal volume or a decreased respiratory rate, they're building up CO2. So high PaCO2 tells me the etiology. It is hypoventilation. So think about that. That's why sometimes you don't even really need to do this equation. If you get the patient's ABG, and from an ABG you get PaO2, PaCO2, you get pH, and you also get bicarb. From this, I can kind of have an idea. If their PaCO2 is super, super high and their pH is low, then I have an idea that it's actually, again, what? More likely, it's hypoventilation. But again, the AA gradient will also give me some type of help, especially if there's associated hypoxemia. So if the patient also has a low PaO2 and a high PaCO2, I can likely tell that their cause is due to hypoventilation, because I can calculate their AA gradient, and if their PaCO2 is also super elevated, it's hypoventilation. Now, here's where it's a little complicated. What if the patient has a normal PaCO2, their AA gradient is normal, this is why it's super rare, so you don't always use this, but normal AA gradient, normal PaCO2, and a low PaO2. Well, now they're not hypoventilating, they're hypoxemic for some reason, but the problem has nothing to do with gas exchange, because the normal AA gradient means that there's no impairment in gas exchange. What was the other cause? Low FiO2. So it's a relatively uncommon situation, but think about it in case it comes up on the exam, low FiO2. So again, when there's a normal AA gradient, there is good gas exchange. This is an important concept here. When there is an increased AA gradient, what you calculate off of their PaO2 and their P-little-ao2, what you calculate in comparison to their actual estimated, if it is much, much higher, that's an increased AA gradient. That tells me that there is impaired gas exchange. And what that will help me to determine is to figure out my differential. And my differential for impaired gas exchange, increased AA gradient, is usually due to a problem where I'm not moving oxygen across the actual, through the alveolar, through the bronchial system. It's not crossing the alveolar capillary interface, or there's a clot within the actual pulmonary capillary that it's not actually pushing blood to the alveoli, or there's a massive shunt. And then lastly, uncommon, there's a diffusion problem. So how do I weed these patients out? I don't want us to focus too much on this one. I want us to focus mainly on these two. So we've come to the patient, we come to the bedside, we see that they have a low SpO2. We appreciate their ABG and say, okay, they have hypoxemia here, so they have a low PaO2. We then go ahead, we utilize our calculations, we get an AA gradient, comes out to be increased AA gradient. So the number that you do when you take big little a, O2 minus P little a, O2, you get a very high number in comparison to what you estimate, which all you do is you take their age divided by 4 plus 4. If the number that you calculate from this is higher than this, they have an increased AA gradient. That leaves you with these three differentials. Once you do that, what I want you to say is, okay, give the patient 100% oxygen. So if they're on some type of oxygen supplementation like high flow nasal cannula or non-rebreather, crank it up to 100% FiO2. What you're looking for is to see, is this a shunt or is this a VQ mismatch? In shunts, it doesn't matter how much oxygen you give these patients. All of these alveoli are clogged up with fluid, pus, blood, or all of the alveoli are not being ventilated because there's a massive mucus plug. And so no matter how much oxygen you try to be able to give this patient, there's no good alveoli that can pick up the oxygen. So whenever I try to send oxygen to this alveoli, to this alveoli, to this alveoli, the diffusion is going to be the same. It's going to be poor. I'm not going to get a lot of oxygen inside of the blood here because there's nowhere for me to vasoconstrict and send blood to pick up better oxygen because all of them are poorly ventilated. Same thing in this situation. No O2 is getting to these alveoli. So no matter how much oxygen I try to increase to better ventilate that entire lung, all I'm going to do is just shunt it over to the right lung. So I might get a little bit of ventilation, but still, this entire left lung is not going to get ventilated. And so because of that, I'm going to develop a massive drop in the O2 because I'm not going to be able to pulmonary vasoconstrict any of the actual vessels to redirect to other areas of this left lung. It's just, I'm going to have most of the blood going to the right lung. All the blood going to the left lung is going to become deoxygenated. That's going to produce a massive hypoxemia despite you giving them 100% FiO2. So if you give them 100% FiO2 and they do not bump their oxygen upwards, it is a massive shunt. So it's due to massive ARDS, pulmonary edema, big Stockton pneumonia, or a massive mucus plug causing an entire lung atelectasis. If you think that they have some type of cardiac shunt, get an echo study with the bubbles to look for bubbles to cross. Get a CT angiogram to look for some type of like pulmonary AVM. If you give them 100% FiO2 and they do improve their hypoxemia, so they do bump their oxygen, that means it could be a mismatch. What that tells me is that maybe there is a little mucus plug here and I'm not getting a lot of oxygen to this one. But if I try to really pump up the amount of oxygen I'm sending to this alveoli, I can still get a more improved ventilation in here and more oxygen to this alveoli and more oxygen to this pulmonary capillary blood. So even though there's very little oxygen getting into this pulmonary capillary blood, if I increase my O2, I can send more of it to other well-ventilated alveoli. And so that may increase my O2 a little bit. Same thing, if I have this area that's either socked up with fluid or blood or pus or it's atelectatic, I'm not getting very good O2 coming into this pulmonary capillary blood. But if I have some other area of lung tissue which is well ventilated, I can send more of the oxygen there and I can help to be able to improve my oxygenation. Last situation here, I have a clot that's actually right here, pulmonary embolism. Even though both of these guys are getting well ventilated, all the oxygen I send to this one, it's not going to be involved, right? It's not going to help because no matter what, there's not going to be any gas exchanges occurring here. So there's going to be a low O2 because I'm not sending any blood here. But if I really well ventilate the other alveoli, that there's not a clot going to that alveoli, then I'm going to send more oxygen into that pulmonary capillary blood and bump their oxygen. So think about that. In situations such as a small mucus plug bronchospasm, small alveolar filling, like a mild or moderate pneumonia, ARDS, pulmonary edema, or atelectasis, or a pulmonary embolism, you can give them oxygen, they'll improve. But if it's a shunt, a big, terrible pneumonia, full-blown severe ARDS, severe atelectasis, severe types of situations like that, no matter what you do, it will not improve it, or if they have an intracardiac shunt or pulmonary AVM. Last situation here. The only thing that I want you guys to remember for this one is that if you give them 100% FiO2, they don't change, it's a shunt. If they do, it's some type of VQ mismatch. If it occurs only when they're exerting themselves, it's interstitial lung disease. That's it. Don't make this too complicated, just say, if they have a decreased diffusion only with exertion, it's interstitial lung disease. I don't want us to go too crazy down that rabbit hole. So how do we go about determining this? If we get to the point where it's an increased AA gradient, we do this test here with 100% FiO2 and we figure out, oh, it's a shunt. How do I determine it? Get a chest x-ray CT to look what's going on with the lungs. Might find a big mucus plug, severe atelectasis. There's my answer. Big socked up pneumonia, bilateral infiltrates with some type of like ARDS kind of picture. Or they have definitely cardiogenic pulmonary edema. Or they have a big kind of diffuse alveolar hemorrhage. Or get a CT scan if you can't see it very well. If you think that they have some type of cardiac shunt, get an echo study with the bubbles to look for bubbles to cross. Get a CT angiogram to look for some type of like pulmonary AVM. If you think, again, here, mucus plugging, you can do a bronch or do a chest x-ray looking for a little bit of atelectasis or bronchospasm. Here, chest x-ray CT. Here, CTPA to look for a pulmonary embolism. These are the ways that you can go about that. Oftentimes with the PaCO2, the hypoventilation, it's a clinical diagnosis. You kind of get it based upon you sifting out through their history and physical exam. This one, super rare. All right. We've talked about all of the diagnostics. Now what we got to do is briefly go through the principles of treatment. All right, so we talk about treatment for these. Now, I don't want us to go too crazy down the depths of like mechanical ventilation and non-invasive ventilation. I don't think it's that important. What I really want you to get is a core concept to treating hypoxemia and to treating hypercapnia. Obviously, the basic concept here is what do you do to really treat these patients? You treat the underlying cause. If it's a brain catastrophe, you're likely going to have to intubate them and treat that disease until they can actually start breathing well on their own. Reverse the sedation if it's some type of drug or particular medication. Reverse that. Flumazenil for benzos and naloxone for potentially some type of opioids. If it's a disease of the chest wall, trying to treat that. If it's a disease of the pleura, thoracentesis. If it's a disease of the nerves, obviously treat those muscles, etc. If you have to treat the underlying disease itself to really fix the acute hypoxia and acute hypercapnia. The the background stuff, while you're treating the underlying disease, you're providing supportive measures, which is the core concept here that I want you to understand. And that may be using non-invasive measures, high flow nasal cannula, BiPAP, or endotracheal tube intubation with mechanical ventilation. But the concept remains the same. And that is, if a patient is hypoxemic, treat the underlying cause of the hypoxemia, but in the interim, how do we fix the hypoxemia? Well, one way is I can try to increase the amount of oxygen, the amount of inspired oxygen that is going to my alveoli. If I increase my FiO2, the amount of inspired oxygen, I might be able to bump the amount of oxygen that's diffusing across the alveolar capillary interface and increase the oxygen within the blood. So think about increasing FiO2 to be able to increase your O2. But be careful, because there is a risk of hyperoxia. So sometimes whenever you start seeing patients who are on very, very high FiO2 levels, so sometimes normal room air is 21%, so you can go up to 100%, but that's very, very high risk of putting the patient of hyperoxia, worsening their VQ mismatch. So we prefer not to go greater than 60%. So try to keep it less than 60%. So you say, okay, Zach, I have a patient who's on Optiflow, BiPAP, or they're intubated and I'm ventilating them on a ventilator, and I have them and their SpO2 is 85% and I have them on 60%. And I can't go any greater. Then what do I do? How do I help to be able to treat this patient? Well, obviously treat the underlying causes, but guess what else you can do? Sometimes the problem with these patients is that they have what's called de-recruitment. So you remember how I told you that sometimes there can be a lot of fluid here, or they can have diseases which are actually they can be compressing on the alveoli, or you're not filling air into the alveoli from like a mucus plug, or you're having diseases that are washing away their surfactant and increasing the surface tension, collapsing the alveoli. Either way, they are de-recruiting. Imagine you're trying to take a deep breath. When you try to take a deep breath, you have to reopen up these alveoli. All right? So you take a deep breath and you have to open up these alveoli. When you try to open them up, then you'll go to this stage here. All right? So you try to take a deep breath, and when you take a deep breath, you try to reopen up and restent these alveoli. That takes a lot of effort, because imagine you have multiple alveoli that are collapsed. And now what you have to do is take a deep breath to work really hard to take air in and open up those alveoli. That takes a lot of work, a lot of effort. So because of that, imagine what I could do to be able to maybe at the end of expiration, so after the patient takes a deep breath in, they fill those alveoli open, guess what will happen if they exhale? They'll go back to this and they'll de-recruit. So in this situation, you have de-recruitment, and here you have recruitment. And this may happen during inspiration, and this may happen during expiration. Wouldn't it be very interesting, at the end of expiration, instead of them actually completely collapsing, I push a pressure into their lungs and keep them open. So that way, whenever they take a deep breath during their next inspiratory cycle, they won't have to work as hard to bring air in. That'll keep them open and keep them able to bring oxygen into them, and then allow for better diffusion of oxygen into the pulmonary capillary blood. So what do I call this when I push pressure into their alveoli at the end of expiration to keep them stented open, to keep them recruited and to not de-recruit? That's called PEEP. And so what I will do is I'll apply a pressure here at the end of expiration, and I'll increase what's called my positive end expiratory pressure. And what that'll do is that'll inhibit de-recruitment. And that'll keep the alveoli stented open so that oxygen can easily move into these and I can breathe easier. It decreases my work of breathing. So it'll increase your O2 and it'll decrease the work of breathing. And then I can allow for better oxygenation. So the questions that they usually will ask is, patient has hypoxemia, you've increased their FiO2 up to 60%, they're still hypoxemic. Should you increase the FiO2 more, or should you increase the PEEP? You increase the PEEP, because it'll keep these alveoli from de-recruiting, keeping them open, and prevent hyperoxia. Okay. The next concept here is hypercapnia. So we have a patient who's hypercapnic. The basic concept that I told you guys, and I really wanted you guys to remember, is that hypercapnia, PaCO2, is dependent upon what? It is dependent upon the tidal volume and the respiratory rate. So if I want to clear CO2, in other words, I want the patient to be able to get CO2 out of their body. I want them to exhale more CO2 out. How do I get them to exhale more CO2 out? Well, I have to increase their minute ventilation. Well, that means I have to increase their respiratory rate, and I have to increase their tidal volume, and collectively, when I increase both of these, that's increasing their minute ventilation. How in the world am I going to do that? Sometimes with these patients, what we may do is treat the underlying cause, my friends. If it's hypoventilation, you treat it. So if it's a CNS disease, you're probably going to have to intubate them because they're not going to be able to protect their airway. You're going to have to do it for them. If it's a sedation, reverse the sedation. If it's a chest wall pleural disease, treat that. If it's a neuromuscular junction disorder, treat that. If it's some type of lung or airway type of obstruction, upper airway obstruction or lung airway problem, then what do? Again, treat that. What happens to be kind of the most beneficial thought process behind this is we can use something called BiPAP. So BiPAP tends to be a beneficial entity for patients with neuromuscular junction disorders or COPD and asthma. Because what we've found is that this can really help to clear CO2, reduce air trapping, and really help to reduce the work of breathing in patients. And so this may be an entity that we utilize in patients with severe hypercapnia, secondary to COPD asthma or neuromuscular junction disorders, especially like myasthenia gravis, Guillain-Barré syndrome, where they kind of act just like this disorder. These tend to be very beneficial to be able to maintain good tidal volumes and respiratory rate that are actually helping the patient to ventilate properly while you're treating their underlying disease. Same thing, there's only really one situation where BiPAP can be used for acute hypoxemic respiratory failure that actually has been beneficial. If you really wanted to remember that, we can use BiPAP up here in acute hypoxemia, particularly in what's called pulmonary edema, secondary to heart failure. So we call that cardiogenic pulmonary edema. And if you guys remember from our heart failure lecture where we talked about this, we went over how it really decreases the right-sided preload and how it really helps to increase the right ventricular afterload and it decreases the left ventricular afterload. And by doing that, the whole concept is that you reduce the filling to the right side of the heart and you increase the blood flow out of the left side of the heart. The whole concept is that you're getting blood flow out of the heart and it's not backing up into the lungs. That's the concept that we would use. So BiPAP is really good as a non-invasive measure in patients with COPD, asthma, neuromuscular junction disorders, where you can control their respiratory rate, their tidal volumes, their overall minute ventilation while treating their underlying disease. And then it's also good for pulmonary edema that's due to heart failure, where you reduce their right-sided preload and decrease their actual left-sided afterload. And that really helps to improve blood flow out of the heart and decrease inflow into the heart. And that'll really help to reduce the pulmonary edema. But this is the basic concept, my friends, that I want you to understand for acute respiratory failure. Let's do some cases now. All right, my friends, let's do a case. Here we have a 65-year-old male, presents with an SpO2 of 80% on room air, and also complains of pleuritic chest pain. Okay, very interesting. So when we do this, we're evaluating for the cause or what type of acute respiratory failure they have. So we do a physical exam. Their heart rate's 120, so they're slightly tachycardic. Their respiratory rate's 32. Their temp is 101.2, so they're febrile. Interesting. And the SpO2 is 80%, so they are hypoxic. So the hypoxic on room air, they're slightly febrile, they're a little bit tachypnic, and they're tachycardic. When you look at their chest and you examine their chest is completely normal. You have no evidence of any consolidation, any pleural fluid kind of problems, or anything like that. So that's very interesting right off the get-go. Makes me think that it's a VQ mismatch likely from no true kind of like consolidative cause. So in other words, it's more of like a perfusion problem, like a PE. But nonetheless, let's go to the next step, which is obtaining an ABG. When we obtain the ABG, what we see here is when we actually look at the patient's AA gradient, it is actually much higher than the estimated AA gradient. Okay, so we kind of went through and we've talked about all of this already, but if we see that the AA gradient that we calculate is way above the estimated, that's an increased AA gradient. That tells me that it's either a VQ mismatch or it's a shunt, or again, it could be like an interstitial lung disease process as well. But I think that's important to remember. So we've already narrowed it down. It's not a ventilation problem. It's not a low FiO2 problem. This is likely a VQ mismatch, or it is a shunt process, okay? So with that being said, let's look at the other aspect here. Their pH at 7.5, so slightly alkalotic. The reason why is because their CO2 is 22. They're breathing probably pretty fast. They're breathing at a very high rate, so they're blowing off CO2 trying to bring in more air, but unfortunately they're dropping their CO2, causing a respiratory alkalosis. And then their PaO2 is 45, so that's pretty low. So they definitely have a pretty good hypoxemia here. So the patient has an increased AA gradient supporting a VQ mismatch or a kind of like shunt process. And so that would tell me that this is likely a type 1 respiratory failure. And I can tell that it's a type 1 because look how hypoxemic they are. Their SpO2 is significantly low, 80%. And on top of that, their PaO2 is very low, 45. And so this is definitely in support of an acute hypoxic respiratory failure or type 1 respiratory failure. All right, so what would be the differential to a cause of a VQ mismatch or a shunt? Well, remember I told you, think about, is it the bronchus? Is it the alveoli? Is it the interstitial fluid? Or is it the pulmonary capillaries that are the problem? And so we kind of go through that process, whether is it a VQ mismatch, a shunt problem, or a diffusion problem, which was the last one that we talked about, which is like an interstitial lung disease issue. But I think the next thing that's really important here is when we think about this, if we think that it's a VQ mismatch or we think that it's a diffusion problem, we could actually give these patients 100% FiO2. And generally what it'll do is it'll actually improve the patient who has a VQ mismatch, but it will not improve the oxygen saturation of those who have a shunt. So if they have a shunt, in other words, they have a intracardiac shunt, they have a VSD, they have some type of PDA, they have a atrial septal defect or something of that nature where they're kind of like mixing blood. That would be an intracardiac shunt. They have a pulmonary AVM. They have significant like mucus plugging of like a primary bronchus. They have massive ARDS, or they have like extreme severe pulmonary edema or pneumonia. In those situations, you can give them a lot of oxygen. If they don't improve, it's a shunt. But if it's like a little bit of mucus in the airways, like a mild kind of mucus plugging, kind of like atelectasis, or if they have a little bit of like fluid within their alveoli, like mild pulmonary edema, or a little bit of pus in their alveoli, like in a pneumonia, or if they have a little bit of blood in the alveoli, like a diffuse alveolar hemorrhage, or they have a little bit of kind of like fibrosis and fluid in the interstitial spaces, like interstitial lung disease, or they have a clot in their pulmonary artery that can also cause like a pulmonary embolism. Those kinds of situations are VQ mismatch. You can give them oxygen and they'll actually improve their oxygen saturation. So if I gave them 100% and it improved, it supports a VQ mismatch. So in this patient, we're actually going to give them 100% oxygen, and guess what? They actually improved. And so that helps me to support a VQ mismatch versus a shunt. So go through your differential. Is it the airway? So in other words, do they have severe COPD, asthma? There was nothing on their actual exam or their history to suggest that. Alveoli, do they have any consolidative findings? No, they didn't. Did they have any kind of like clear, crackles or rails on auscultation? No. Atelectasis, did they have any kind of like decreased expansion on one side? Any kind of like decreased tactile fremitus? Any kind of dullness to percussion? Anything that would suggest that? No. So could it be a PE? I think it could be a pulmonary embolus, especially with the patient's tachycardia. That also is in support of that, especially with a normal lung exam. And then the next thing, their chest x-ray shows no evidence of pneumonia, pulmonary edema, diffuse alveolar hemorrhage, or atelectasis. They have no wheezing on auscultation. They don't smoke. They have no history or remote history of COPD. You get a CTPA and there it is. Boom, a big saddle embolus kind of straddling the right and left pulmonary artery. So we know that the patient has a proximal pulmonary embolism, and that's their cause. All right, so let's move into the next case here. Case study number 2. Got a 45-year-old male, status post-opioid overdose, presents with SpO2 of 88% on room air. So physical exam, heart rate's 50, respiratory rate's 6. Okay, they're not breathing very much at all. Temps normal, SpO2 is a little bit low, probably because they're not breathing very well. GCS is 7, so they definitely have a decreased level of consciousness, likely because they probably took way too much opioids and they're having a degree of CNS depression and sedation. So With that being said, let's obtain the ABG, utilize that to help us to determine the AA gradient, and then what other kind of problems they have. So we look at the pH, 7.24, so slightly acidotic. Why are they acidotic? Is the CO2 going to be high, or is the bicarb low? Bicarb is appropriate, but the CO2 is 62. That's elevated. So they're not really breathing very much, so their minute ventilation's low. Their respiratory rate's low, so they're not actually exhaling as much CO2, so CO2 is increasing, bringing the pH down. PaO2 is actually a little bit low, but nothing crazy, but it's mildly low. So it's likely mildly low because they're not ventilating as well. And so because they're not actually taking in adequate amounts of ventilation, they're probably not bringing in as much oxygen into the bloodstream. So they also have a little bit of a hypoxia as well in this situation. But then we go to the AA gradient, so we calculate the PaO2. We utilize that to calculate the AA gradient, and we obtain that that's 7.5. The estimated is 15.25, so it's not increased above the estimated. So it's not an increased AA gradient. Therefore, it is not a VQ mismatch. Therefore, it is not any type of problem with a shunt physiology or diffusion problem. This is either a low FiO2 that they're inhaling because they're at high altitudes, or it's hypoventilation because they're not generating an adequate respiratory rate and depth, which is likely because they took too many opioids, suppressing their respiratory drive. They have a decreased respiratory rate and depth. They're not adequately ventilating properly. So that would likely be the potential cause for this patient since they have a normal AA gradient. And this is definitely going to be an acute hypercapnic respiratory failure or type 2 respiratory failure. So what's the differential? We already said that it's likely going to be either due to low FiO2, maybe there's some kind of like problem where they're not having enough oxygen in the tank, or you're not breathing enough FiO2 via the device that you're using, or you're at high altitudes, or the other potential etiology is that there's hypoventilation. So in this patient, they're not taking adequate tidal volumes. This could be due to a decreased respiratory drive, like a CNS depression or CNS disease, so stroke, seizures, brain masses, something of that effect. Or there's a problem with the nerves going from the spinal cord to the actual skeletal muscles. So something like ALS or something like a spinal cord injury. It could be Guillain-Barré syndrome, so actually like demyelination of the axons there. It could also be due to myasthenia gravis, so there's neuromuscular junction problems. Or it could be due to myopathy, so muscular dystrophy, or it could be due to a myopathy of the muscle, or even sometimes it could be due to weakness or fatigue of the muscles. In other words, the patient's been breathing heavily and fast and deep for a long time, and those muscles are fatiguing out because they can't maintain this adequate kind of like this high respiratory rate. So those would be things to think about as a potential etiology here for this patient. So it's likely hypoventilation is the potential cause. And then again, we can go through and think about all the reasons as to why they would have this potential problem here. And again, we can say it could be due to a CNS disease or depression. It could be due to a nerve problem or a neuromuscular junction disorder. Another thing is it could be due to a chest wall or pleural disease. So I didn't mention this, but sometimes if a patient has like ankylosing spondylitis or some type of like abnormality in their rib cage where they aren't able to adequately take deep breaths because of their anatomy, that could be a potential problem. Or if they have big, huge, whopping pleural effusions that are compressing down on the lungs, or big pneumothorax that are compressing down on the lungs, if they try to take a deep breath, they can't take a deep breath because it's not going to allow for the lungs to expand because they have this restriction of the lungs. Or they have obesity. So sometimes if you have obesity, it actually restricts the lungs from being able to properly expand. So that could be a potential issue. And then the only other thing that could be is an obstruction of the airway. So generally, if they have an obstruction of the airway, that'll allow for less air to come into the lungs as well. So those are things to think about. I think that the patient's etiology is CNS depression, though. All right, so if that is the case and it is CNS depression or opioids, how do we treat that? We reverse that, usually give them something like naloxone to reduce or reverse the actual effects of the opioids, and generally the patient should improve. All right, my friends, so that covers acute respiratory failure. I hope it made sense. I hope that you guys enjoyed it. Love you, thank you, and as always, until next time.